This is number 9 in the series of the neuroanatomy lectures. The lecture today is on reflexes and ganglia. So we're going to go through the reflex arcs, which don't go directly to the brain, the ganglia, and then some pathologies of the nervous system, specifically the axons and things that affect neuronal transmission, and also some of the vitamin deficiencies that affect the nervous system. So the reflexes, ganglia, and the ganglia are divided into these 3 types that I can see. There's probably more because ganglia is just a general term for a swelling or cyst-like appearance. So ganglia can include synapses, unipolar cell bodies, or cysts. And then, of course, the pathologies that will include myelination and some of the vitamin deficiencies. The first thing are the neurons in the reflex arc. And this is an example of when you're going to the doctor and you're checking for reflexes. This is an example of the patellar reflex. First question, what is a true statement? Reflexes are present from birth. B, reaction time requires myelination and practice. Both are true or neither are true? The answer is true. Your reflexes are present from birth. Corneal reflexes, of course, you've got to, if anything comes close to your eye, you've got to be able to protect your eyes, so that's there. Reaction time, on the other hand, requires myelination and requires practice. You can't come out of the womb and be able to walk right away. Reaction time is the example above here. We gave in the last lecture talking about drivers, professional drivers, for instance. And then reflexes are the hardwired into your body. This is an example of a reflex arc. It showing here where the skin, you touch something hot and you automatically jerk back without thinking about it. Eventually your brain gets the idea that you've touched something hot, but in the spinal cord, it goes through this reflex arc where you have this sensory ganglia right here, picks up the transmission, and just a interneuron within the spinal cord jumps across and then hits motor neuron, and then your motor fibers react and you jump back. So breaking it down into all the different cells, as I mentioned, between the cells is this interneuron, this green image right here, interneurons. So it connects the sensory nerve and to the multipolar motor nerve. So here's the sensory nerve. It's coming in, it's a unipolar neuron. See, it's only got one stalk coming out of the cell body. And this dorsal root ganglia is accumulation of multiple cell bodies. So it causes this swelling. That's the dorsal root ganglia. So it's coming from your skin, sensory, interneuron, and out the multipolar neuron going to the effector or the muscle. So quick test on your memory. What is contained in the dorsal root ganglia? And the dorsal root ganglia is right here. This is an anterior view. This is the spinal cord and the vertebral processes. Is it a neural synapse, a unipolar cell body, or fluid? And this is the dorsal root ganglia. And the answer is it's a unipolar cell body, accumulation of multiple cell bodies. This is a good image showing all these different swellings. The sympathetic chain comes off on either side, comes out of the thoracic, as well as the lumbar vertebra. That's the sympathetic chain ganglia. And these are the unipolar cell bodies. So these are synapses, and these are cell bodies. The dorsal root ganglia containing cell bodies. This is a disease called trigeminal neuralgia. Very uncomfortable, very painful. The cause is unknown, could be viral, could be an autoimmune disorder. It's severe pain in the sensory distribution of the trigeminal ganglia, which is a cranial nerve 5. And it has all of these outputs that take sensory to your face. The possibilities for treatment, besides numerous things, medications, steroids, multiple things to treat it. If none of those work, they can actually destroy the ganglia. This is more of a last-ditch effort, because if they destroy this ganglia, they may go ahead and get this permanent numbness, which is very distracting to have permanent numbness of the face. So this trigeminal ganglia is just like a dorsal root ganglia for the spinal cord, for the peripheral nerves. But instead of a dorsal root ganglia, the cranial nerves have their own ganglia, their own sensory ganglia, since they're going to the brain rather than having to go through the spinal cord. So this is the underside of the brain. And this is looking at just some of the cranial nerves with sensory ganglia. The first one here, A, cranial nerve 1, is the olfactory nerve, and this is showing the olfactory bulbs. They represent the unipolar cell bodies of cranial nerves. The optic nerves are actually, as in shown in B, the ganglion for them are actually in the back of your retina. And then here is another vision, another view of the cranial nerve 5, the trigeminal ganglia, near the base of the brain. So the ganglia are outside of the brain, they're next to the brain, but they still represent unipolar cell bodies. Now, another ganglia you'll hear about is a ganglion cyst. It does not contain any neural elements. It is just called ganglion because it's because of the shape. And the treatment used to be, the old treatment was the Bible, smacking it with a big Bible, or now if it doesn't remove with aspiration with a needle, they can actually remove it and just this is surgical removal, taking the whole cyst out, because they generally recur if you aspirate them. So basically there's 3 types of ganglia. The first type is the unipolar cell bodies. They're the sensory nerves, within sensory nerves, accumulation of those unipolar cell bodies. The second type are the synapses between nerve cells, and that's within the autonomic nervous system, either connecting the presynaptic neurons near the spinal cord, as in the sympathetic chain, or right next to the organs, as in the parasympathetic nervous system. And then the third type is that fluid-filled cyst. Okay, now we're going to get on to axonal transmission and some of the pathologies that can affect that. Now, as a review, remember the myelination of the axons allow for greater transmission speed. and they prevent any signal fade. So it's like the insulation on the conduction wires in your home. Demyelination. I'm going to go through some of the causes that will cause demyelination. You start getting sensory loss and some motor loss. With demyelination, like I said, you can get sensory loss, but also your ability to walk, ability to think clearly gets impaired. And the different causes that for demyelination include multiple sclerosis, which is either genetic, autoimmune, and then you can also see demyelination with malnutrition, specifically B12 deficiency will cause demyelination. So with B12, the way I remember it, B12, 12 inches equals a foot. So you have 2 feet, foot 1 and foot 2. And they usually present with peripheral neuropathy beginning at the feet. So that's the best way to remember B12 deficiency symptoms, peripheral in the feet, and B12, foot 1 and foot 2, 12 inches, B12 deficiency. Do you remember from previous lectures the cells that form the myelin in the peripheral nervous system? Are they oligodendrocytes, or are they called Schwann cells that are responsible for the myelination in the peripheral nervous system? The answer is Schwann cells. The way to remember that from my little mnemonic from previous lectures, Schwann company delivers. It's in the periphery, delivering to people's homes. B12 deficiency causes this demyelination of the peripheral nervous system. And it can be caused by a couple things, either gastric diseases, and also people who've had gastric bypass surgery need to be supplemented with B12. Multiple sclerosis, on the other hand, affects centrally. So it affects oligodendrocytes, or the myelination cells within the central nervous system. And the way I remember that is oleomargarine within the brain, oligodendrocytes. All right, this is a reminder, just a quick review. What vitamin deficiency increases the risk for neural tube defects? Is it folic acid or vitamin B1, thiamine? The answer is folic acid, B9. Let's see if we can remember that. I used to give this lecture for, well, I always give this lecture in the spring semester, right around Valentine's Day. So I always talk about, you know, the love that happens around Valentine's Day. B9 is the name for folic acid. With folic acid deficiency, you'll see anemia, neural tube defects. So remember, your neural tube for your spinal cord closes within 21 days of pregnancy. So sometimes people don't even know they're pregnant, and the babies are already forming their neural tubes of their spine. It can cause also cardiovascular disease and cancer in adults. So it's recommended that older adults also take prenatal vitamins with folic acid. So this gets into anemias, because a lot of these vitamins and mineral deficiencies will cause anemias. So normal, here's on the left, normal blood containing red blood cells, white blood cells, platelets. and anemia, fewer red blood cells. So the three things that can cause vitamin mineral deficiencies that can cause anemia include low iron, B12, and also folic acid, so B9. But they have a different presentation. If you look at peripheral blood smears, you can see that there's a difference between how these cells are shaped, and rather specifically how they're sized. Macro means they're big cells, macrocytic, big red blood cells, and microcytic is they're small red blood cells. Do you know the most common cause of anemia? Is it iron deficiency, B12 deficiency, or folic acid deficiency? And your hint was there, iron deficiency is the most common cause of anemia in people. Iron deficiency anemia, iron is needed for hemoglobin synthesis. So if you have few hemoglobin molecules, you end up with very small red blood cells, and that's microcytic. So micro is small, cytic is cell, so you see a microcytic anemia with iron deficiency. In contrast, the anemia caused by B12 and B9 is macrocytic anemia. B12 and B9 are needed for DNA replication, so it's very early on in the cell cycle. And what you end up with is with very few but very large red blood cells. And macro is large, a macrocytic anemia. Few red blood cells, but they're very large. So showing you the pathophysiology of all of this. In the bone marrow is where all the blood cells are being grown, developed, replicated, starting with these single stem cells. And within them, their DNA is replicating and they're producing red blood cells. As the red blood cells are formed, iron is incorporated to create the hemoglobin molecules, which will carry the oxygen for delivery to the tissues. And as the red blood cells become mature, they're kicked out of the bone marrow. But before they go, they lose all of their organelles. And all they've got are the hemoglobin molecules containing the iron that will be carrying oxygen. So looking at the pathophysiology, looking at how stem cells are producing red blood cells, you can see how you separate it into the macrocytic and the microcytic. The macrocytic, again, is from B12 or B9 deficiency. DNA replication is inhibited, so you end up with these large red blood cells with B12 or B9 deficiency. And on the other side is the microcytic anemia, when there's low iron, poor hemoglobin synthesis, and you get these anemic looking few small red blood cells with iron deficiency. All right, let's look on some more vitamin deficiencies causing neural damage. This is a syndrome, Wernicke-Korsakoff. It is a very late stage of thiamine deficiency, or B1. B1 deficiency, usually you'll get patients that'll come into the hospital being treated for some other problem, but they may be alcoholics and have poor nutrition. But you can also see it as actually more commonly now for patients having gastric bypass surgery. and they have thiamine deficiency. The problem is with gastric bypass surgery, they bypass the first part of the duodenum, or the whole, actually the entire duodenum in gastric bypass surgery. And if B1 is not supplemented either in their diet or vitamin supplements, they can develop what they call Wernicke-Korsakoff syndrome. The pathophysiology of this, B1 deficiency, thiamine is needed to make both the Schwann cells and the astrocytes. Remember, the Schwann cells are in the peripheral nervous system myelination, and the astrocytes protect the blood-brain barrier. So without these cells, what happens to the brain? So do you remember how astrocytes protect the brain? Do they create the blood-brain barrier? Do they clean up pathogens, or do they produce cerebrospinal fluid? And I just told you, so this is super fast recall. And the answer is they create the blood-brain barrier. They surround the cerebral blood vessels and protect any pathogens from leaking out of the blood vessels into the brain. So what happens with thiamine deficiency, the symptoms are the oculomotor. So it's affecting those nerve cells. Cranial nerve 3 innervates the nerves of the eye. So the weird eye movements, they affects the myelination, peripheral nerves. So people have trouble walking, and they can have amnesia or altered mental status because it's affecting the blood-brain barrier. So you might have thiamine deficiency in someone who's an alcoholic, and you might write off all of these abnormal symptoms as being someone is being drunk, but it's actually thiamine deficiency or Wernicke-Korsakoff syndrome, Wernicke-Korsakoff. So to remember this, thiamine deficiency, vitamin B1 deficiency, here's a bee drinking a beer, and he's saying, don't be one of these guys. So in summary, we've talked about reflexes. We've talked about 3 types of ganglia: synapses, unipolar cell bodies, and cysts. We've talked about pathologies, things that affect myelination of the axons, and also some of the vitamin and mineral deficiencies. We got a bunch of stuff. And for your question slide, I put in some of the sources of vitamins: folic acid, B1, B12, and iron. I'm going to include the PDF for this in a link that you can find within the description of this YouTube video. And I thank you.